Welcome back. Let's talk malaria and World Malaria Day, which is today. We're being joined in the program by the Commissioner for Health in your state, Dr. Oluwaseremi Ajetumobi. She joins us via Zoom. Thank you so much, Doctor, for coming on the program.
Thank you. Good morning.
All right, let's get straight to business. When you look at the numbers in terms of deaths and cases in their millions across sub-Saharan Africa, which Africa is high burdened when it comes to this issue, one wonders why the continent is so high burden, bringing it down to Nigeria, when it's a primary healthcare issue.
Thank you very much. The malaria burden, malaria itself is a global disease, and it's also a life-threatening disease as well. And the burden is high because a lot of things are not in place, particularly in our people. You know, there are some myths against malaria. People feel that it's only children that are affected by malaria, whereas everybody can have malaria. People feel that when you have malaria once, you cannot have it again, whereas you can have it again because what causes it is in our environment, the Plasmodium protozoa. And also we need to create awareness now for malaria, letting people to know the high burden that we have, the life-threatening situations, the fact that if malaria occurs and is not treated on time, it can progress to life-threatening conditions which can end lives. So we need to create more awareness, and that's why the 2024 World Malaria Day, the theme is accelerating the fight against malaria for a more equitable world. Because we find out that too many people, they miss out on ways to assess, either to detect, to prevent, or even assess treatment when it comes to malaria issues. And who are these set of people? We have the vulnerable, the children under 5, pregnant women, those in the IDP camps, the migrants, all those people that they are facing high degree of poverty, and also the vulnerables, those that are excluded by virtue of what happened to them. These people do not have access to the hospitals, access to care, and to get treated even when they have malaria. So the thing now is that everybody is now creating an awareness to fight this body so that we can have malaria-free country or malaria-free state. So we are bringing it out like it's a kind of community awareness. It's a kind of community engagement, community participation. Bringing in our faith leaders, the imams, the clergies, even in our schools, to teach them on how to recognize these symptoms. And when the symptoms occur, what are the necessary things that they need to do so that they can get treated. Recognizing the symptoms will mean that, okay, anybody that you find having fever, and though not all fever is malaria, but at least when you have fever, intermittent fever means that, okay, the child is free this morning. When it's getting towards evening, the child begins to run fever.
Right.
So those are intermittent fever. But a child is presenting with fever, at least we should have, as part of our diagnosis or as part of our suspicion, malaria. And when that occurs, coupled with the fact that the child is not eating well, it's having a kind of vomiting or wants to vomit, and maybe complaining of headache, we all should take that particular child to the health facilities around us. Primary health care, just as you said. Primary health care is closer to us. And for example, in Oyo State now, the governor of Oyo State, Engineer Seyi Makinde, has refurbished over 211 primary health care facilities.
Right.
And they are equipped with things that they can use to diagnose malaria. For example, we can diagnose malaria using rapid diagnostic test, which is FAT, is a point of care test. And also we can use microscopy. We don't have too many microscopists, but we have RDTs around in all the primary healthcare centers, right, where people can go to and they can get tested. And when they are tested and it's positive, they have drugs, even at the primary healthcare centers, given to them free of charge. The testing is free and the drugs are also free.
Well, doctor, you know, there's what is ought to be,
right, the ideal situation, and then there is the reality on ground. And particularly for your state, I remember as far back as 15, 20 years ago, the University College Hospital, so there's this segment of the hospital that does a lot of research about malaria, and I remember spending time there, and you see day in, day out, women, children coming in, you know, with malaria, some of them acute. Now, I don't know how far that has yielded, particularly research into that has yielded results, but it looks like there's still a lot of prevalence. As you said, Oyo State is trying to beat that, have zero, you know, malaria in the state. So speak to us about why it has been tough to really, you said there's a perception issue and the rest, maybe cultural as well. Why has it really been tough to, you know, get the information down? Because the way you sound now, it sounds really easy. But when you get to those areas, and I don't want to mention those rural areas, some of them are notorious for that, the case is quite different. So have you been able to find out what exactly is responsible for that?
Yes, in the state now, the prevalence has reduced. We have like 21% prevalence of malaria in the state now. We have hard-to-reach areas, and hard-to-reach areas, they are security compromised. So many a times, accessing those areas becomes difficult. And what we do now, when we want to access the areas, is to have some security personnel following the people that will go there, so that with that, we are rest assured that whatever is there, they will handle the situation. That is number one, how to reach areas. These people, they don't have access even to listen to radio or to watch televisions, so they don't even know what is going on. The ways of preventing it, they don't know. And we have levels of prevention. One of the levels of prevention is health promotion. Health promotion, as we are doing now, you can engage, you can give information, you can educate people. Some of these people, they don't have access to all these facilities. So we have to go to them to be able to preach the gospel and say, okay, these are the things that you should do. Then culturally, people like that stay in poorest areas where you can find dirty environments, bushes around them, that we need to tell them to clear the bushes, to take care of their surroundings, and also hand to them insecticide treated nets as a way of vector control for them. So those have been the challenges over the years. You want to do it, and people are afraid of going to those areas because of security challenges. But we are overcoming that in the state gradually.
Okay, so speak to us now about some misconceptions, if I could call it that. So you go to the hospital because you're ill, and you get tested. They tell you there's +1+, 2+ malaria, and the rest. And it's been said that, well, there's always malaria in the body, and I've heard that before, that there's always a parasite in the body. So from time to time, it just undulates. So sometimes, if your immunity drops, it will increase. If you have good immunity, you will not experience it. Some other people have said, well, it's when you get bitten by, you know, a malaria parasite carrying mosquito that you get infected, and it will show 3 weeks after. But clearly, it looks like for a lot of people, whatever happens, it's always malaria. So speak to us. Is there always malaria in the body? So what you just see is a manifestation of what's been there, or it's as a result of new bites per time?
Thank you very much. We know we have different species of Plasmodium protozoa that causes malaria. We have the one that we call P. falciparum. And that one, the incubation period is just between 7 to 30 days. And it's preventable, it's curable. It does not have what we call like a dormant phase in the liver, whereby it can persist for a longer time, and people can get infected and have the malaria again. So the fact that you go to the hospital, they test, you get tested, and they pick positive malaria parasite, and you are treated at that particular instance. If it's P. falciparum, it does not have a dormant phase, so there's nothing like relapse, except the malaria is not properly treated. But we have other species, like P. malaria, P. vivax, that they have dormant liver phase, and that one can persist for 2 to 3 years. So those ones are the ones that are called relapsing fever. But for P. falciparum, which is global, which is throughout all the tropical regions, it does not have a dormant phase and does not cause relapsing fever. The only thing is that probably the person is not well treated. And because it's not well treated, the parasite still remains in the bloodstream. And that's why you see people saying they have malaria. The notion around us is that all the fevers is malaria, whereas it is not. And that's why we need to get tested. The teaching now is that any fever, you test it for malaria, because a lot of things can present with fever as the symptoms, and it may not necessarily be malaria. So it's not all fever that is malaria. And the people should know that they need to get tested. Once you are tested by RDT and it's positive, you are likely sure that even microscopy, which is the gold standard, will also be positive. But once it's negative and the person has symptoms of malaria, the classical symptoms of malaria, then one can say to that person, go and do microscopy. And if the microscopy is positive, the person gets tested. And nowadays, we talk of artemisinin-based combination therapy. It's not monotherapy again, like use of chloroquine or use of fancida. So many a times people go self-medication. They will say they want to take chloroquine or they want to take fancida, and that one may not even touch the parasite at all. So they may come back to say that every time they are testing, they are having malaria because it's not well treated. Those are the misconceptions around it.
Speaking of misconceptions, we'll get to that as, they're affected by attitudes. But the good part is that there is hope for, overcoming the malaria challenge with the RTSS vaccine, which we gather has already gotten to some African countries, but Nigeria has been excluded due to some reasons. But getting to misconceptions now, there has been talk about, our inability to achieve universal immunization coverage because of attitudes to vaccines. Peradventure, the malaria vaccine gets to Nigeria sooner than later. What attitudes, yet again, do you find that could affect, taking full advantage of this malaria vaccine to defeating this public health challenge?
Thank you very much. The usual thing that will happen is this vaccine hesitancy. People may want to hesitate and say, okay, let's see those that are taking it, what will happen to them? And if nothing happens to them, they may likely change their mind. So vaccine hesitancy is one of the things that we could experience. But the way to go around it is just community sensitization, community awareness, letting them to know the burden of malaria, the symptoms of malaria, and the way that the vaccine will be included in the routine immunization of children. And probably will be taken from 5 months of age, and the doses will be spread out like that. But usually there may be vaccine hesitancy, and a lot of cultural interplay may come in, because people will say, don't go, if they give you something like this will happen. But with media engagement, with community sensitization, with community engagement, involving our faith leaders, the imams, the clergy, preaching it in the church, preaching it in the mosque, I'm sure we are going to get around it. And anybody that has witnessed we have what we call mild symptoms of malaria, and we have life-threatening symptoms. So just to say that we have what we call uncomplicated malaria and severe malaria. Now, for those that have had children with severe malaria and coming down with complications like the child has attained some developmental milestones, but because of severe malaria or cerebral malaria, for example, the child regresses from the developmental milestones that the child has attained before. Or the child has what we call cortical blindness as a result of cerebral malaria. So all those ones can be an example to people to say that if you don't treat this thing, these are the complications. And when people see complications, they see it themselves, they'll be able to change the attitude.
So let's stay with the issue of the vaccine. I'm a bit curious, because when you look at the R21 matrix M malaria vaccine that Gavi is proposing, you can see that it was developed by the Oxford University or University of Oxford and manufactured and scaled up by Serum Institute in India. Is yes. Worrying and disturbing to see, which is why this hesitancy is a challenge. Africa is high burden. Nigeria is part of Africa, and we're high burden as a continent. Is this a problem? The reason I'm asking this is more of a political question, but you're a commissioner, so you understand the politics around this. Is it a problem of lack of value for human life, or what exactly is going on? Because If we're this high burden, why are we waiting for the global north to come to our rescue for things that impact us negatively?
Thank you very much. It's not because of lack of care, but you know, when it comes to development of vaccines, a lot of things are done at the background. It has to go through some form of clinical trials. They are going to test it to be sure that when they are given to human being, it's not going to cause, the harm will be less and the benefits will be high. So those are the things surrounding the vaccine. And more so, by the time it's coming, it's not going to be cheap. So they need to weigh the modes of operation, how to go about it, particularly because we know that this is a challenge among children under 5. And most times when it's coming like that, it has to be free, in quotes. And for that, a lot of things have to be put in place to be sure that we are ready for it. Not just that we get vaccines and at the end of the day, people are not getting it and we are wasting the vaccines. I think those are the issues around it.
Madam, my question is, we are the ones with the problem. Why are we waiting for the global north to solve our problem, which should be some level of emergency? Because you're talking about we have to be tested. We have universities. I read deliberately that it was developed by the University of Oxford and scaled up by an institute in India. What is Africa doing? You are the scientists in this space, because at the end of the day, we can't keep just waiting for people to lump things on us who are not high burden, which is part of the reason for this hesitancy. People are saying, you're not the one that has a problem, we have a problem. Why are you providing solution for us? So across board, you're going to see that hesitancy.
Yes, for the development of vaccines, you are talking of scientists, you are talking, and I'm sure for us to be saying what we have today, the vaccine is the second one, apart from the 8301. And for them to have come down with a lot of things are coming to, a lot of things are gone that we can't see. And I'm sure for us in Nigeria, we have some malaria technical working group that are also working assiduously to be able to see that we can have this. But it's just that until you break the ground, you may not know what is going on. I think that's my answer for that.
Well, I just want to expand this a little bit more, because I know that there was a talk about a ban of styrofoam in your state. You're also, of course, part of those championing that. And we know that eventually what happens is the styrofoam and waste, they block drainage paths, which makes for stagnant water that breeds mosquitoes. And then, of course, the rest is history. It's quite simple, really. So speak to us about that particular ban, the enforcement, because I think this will also be vital to the fight against malaria, because we know how stagnant water is a perfect breeding ground for mosquitoes. So perhaps we can get some updates on that ban and the implementation.
In Oyo State, the governor has health as one of the cardinal pillars, and not just about the clinical symptoms alone, it's also about the environmental conditions of people. And right now, a lot of effort is in place to make sure that there's no drainage blockage by all these delts, all these styrofoams. If anyone picked now, is going to pay fines. So people are being encouraged to not to drop anything in the gutter, not to block the waterways, and also to put their waste in the appropriate place. And the education is ongoing too, as touching the use of styrofoam, because it's not easily degradable. And because of that, a lot of toxins is being released. And if such should block the drainage to really, they may cause pools of water, stagnated pools of water, which can aid the breeding of mosquitoes. And for that, the state government is doing a lot to make sure that we have surroundings clean in terms of hygiene and cleanliness. Waste are being put where they're supposed to put it. And anybody find culpable is sanctioned by way of fine. So we are doing that in the state now.
And as we wind down gradually, I'd like you to respond to yet another public health challenge, but which really is institutional in nature. I'm talking specifically about the concern about unwholesome reports that, you know, we usually read about, the University College Hospital, Ibadan. You probably say that it's a federal institution, but it's serving the state capital, 4 million residents, if I'm correct, you know, by the figures of the population in your state. Is there any intervention that the state government is provided such that the alleged corrupt practices being perpetrated in that institution can be nipped in the bud, such that, you know, it can begin to serve the needs of the state, you know, more efficiently and more transparently?
Thank you very much. You know, we have levels of healthcare. We have the primary healthcare, we have the secondary healthcare for the state, and the tertiary, which is University College Hospital. So the State Ministry of Health, it's work together also with the University College Hospitals. Many a times when there's alleged of something not good, it's not actually the truth. It's when you get there, they'll be able to know what is going on. Even though I know that for healthcare workers, we have some attitudes too, which we are trying to work on, to say that approach and communication is very important, because at times you may come to the hospital, what I'm communicating to you at that particular instance, you are saying 6, whereas I'm saying 9. So there may be a communication gap, really. But the so-called alleged situations that you hear or read are not actually the truth of the matter. Is when you get there, they'll be able to know that a lot of things have been done for that particular people before they now come. It may be because of maybe communication gap, or they want things that at that time the facility is not able to provide. But sincerely, the University College Hospital, the State Ministry of Health, and even the Oyo State as a whole, we work hand in hand. There are some of our cases that we can't manage at the secondary healthcare level, that we have to refer to them, and they take it. They help us to see them by the virtue of the specialists that they have. So some of these things that you hear or read on media are not exactly the truth. That's what I will say for that. But for the state and the federal, the University College Hospital, we work hand in hand. Their consultants come to our secondary healthcare facilities to train our residents and to offer one form of surgery or the other for us. We have them that are working in the state as well, like a kind of giving back to the community.
All right, Dr. Oluwaseremi Ajetumobi, Commissioner for Health, Oyo State. Thank you so much for coming on the program, madam.
Thank you, and good morning.
Absolutely. When we come back after this break, we'll talk that GMO thing, that debate about GMO. We'll find out details of this and how safe it is for all of us right here, or whether or not it is safe. That's a question we intend to answer when we come back. Join us again